So what really brought the paradigm change in spine surgery, and now we have brought it to a stage where we do the surgery if needed, say in close to around 10% patients, by transforaminal endoscopy, which is a stitchless surgery under local anesthesia. Mind you, it is stitchless and under local anesthesia, whereby you can take care of any morbid patient with comorbidities in the form of diabetes, and other medical conditions. So what really changed after start of stitchless spine surgery under local anesthesia? This change brought in the symptom matrix, which I have published, and the clinical cascade rather than the degenerative cascade by Kirkcaldy-Willis. We realized that it's not infinite diagnosis or infinite possibilities in the low back pain and sciatic pain, but there are 6 symptom groups which give rise to suffering in the patient, and that led me to develop my algorithms with the help of my friend Dr. Ihab Hosni from Egypt. Then we also now realize that there is a group of patients which have got facet related problems which can give rise to back pain on the paraspinal area or claudication, and in that there could be a subgroup where there is instability which needs fixation, which can also manifest as claudication. Related to the disc, we can have back pain when the posterior annular tear is central, or leg pain when the tear is posterolateral. There could be a subgroup of knee and heel pain and coccydynia. Here I must mention that when you have a disc herniation, it can have 3 types of disc herniation. One is what we call as a soft herniation, where the nucleus alone herniates, comes in the epidural space, is sequestrated. The pain is very severe to start with, but can settle on its own in about 2 months' time. If the pain is taken care of, the pathology changes and a fragment is dissolved or eaten away by the macrophages by phagocytosis. Type 2 is a herniation where you have a soft herniation with a piece of annulus in addition. This may take about 6 to 8 months to go away as far as symptoms are concerned, due to reduction in the inflammation, reduction in the nuclear piece, etc. But the outcome is uncertain, and we can't be so sure that it would go away in 100% of them. In fact, it may not go away, and the healing of the annulus could be only partial, and which may give rise to persistence of pain. So this could be one of the group which may need surgery. The third type is where you have a soft nucleus with a hard annulus and a piece of end plate which has fractured. So this is a very hard piece, and normally, theoretically, it may take up to 2 years for us to get relief of that pain, but again, it is uncertain. Now here I must mention a common argument done by non-operative treatment giving surgeons, that you know what, at the end of 2 years, everything is same. I say no. This statement is twisted. I can tell you that what takes 2 years for the nature to resolve, I can resolve in 1 day by my surgery, which is stitchless and under local anesthesia. Now, if we go into the basics of all this, we will find that there is hardly any study of healing of the annulus and the related repair strategies. We have published severally on these issues, and that would be a separate topic. I have recently added a chapter to a textbook on behavior of the posterior annulus and repair strategies by surgery or conservation. We have also proposed a solution in the form of platelet-rich fibrin plug for repairing the annular opening, which we commonly use in our surgeries. The reality of ligamentum flavum and stenosis. There are multiple misconceptions. There is cheating, there is fraud going on, and these could be mentioned in short as the mention of bony hypertrophy, the cross-section plane in the images. In routine images which we do today is the disc, which should be the facet. The true anatomy of the ligamentum flavum in cadavers can only be understood by ventral dissection and not by removal by interlaminar axis and a dorsal axis and a dorsal dissection. Then we also have 3D imaging and fusion images which actually show us the real anatomy of the ligamentum flavum, which is absolutely different than what we know today. And then we have diffusion tensor imaging in MRI, which tells us what we should do to treat the patients who need surgery, where they have a multiple affection at multiple levels giving rise to claudication. And one more thing which we have added to the understanding is doing ultrasound examination in every patient above the age of 65 for post-void residue estimation. Why? Because post-void residue indicates that the patient may be harboring a neurogenic bladder or a dysfunction of detrusor. What we have seen is many patients land up with retention of urine after the surgery, and then we always come back to the saying which I have proposed, that whatever you talk before surgery is science. Whatever you talk after surgery may be used as defense. So please remember, we will talk about this stenosis and the frauds in a little while from now. Now this is Kirkcaldy-Willis degenerative cascade, where we know that the facet joints are undergoing changes, the disc is undergoing changes in the form of tears, etc. And there are three stages which are proposed as dysfunction, instability, and natural stabilization. Now please remember that natural stabilization is over-exploited by traditional surgeons to propose stabilization for everything, because they feel that that is the natural outcome, therefore they should stabilize. It has no scientific validity except in patients with deformity or instability. So what I have done is I have published on this as my matrix, which forms the basis of my surgery under local anesthesia. And what is the matrix? There are 6 clear-cut symptom groups. The first one is low back pain, which could be vertical or horizontal, but it is a pain along axial skeleton. The patient's pain may centralize or peripheralize on doing Mackenzie's test. This test is essentially lying prone on your belly and then asking the patient to extend his back, the upper part of the back. Lift the chest off the bed while lying prone on your belly and look for the location of the pain and the change in the location of the pain. The pain will change from periphery towards the center. This test indicates that the annulus has a good integrity. And in these patients, if we give a distal block, which we'll talk about in a while from now, then this patient can be treated by non-operative measures. And we also use these two tests to monitor the conservative treatment. Now, imaging is done to confirm the containment of the disc, because here the disc is contained, the outline of the disc is not changed, and there are intra-annular changes. The basis is there is an annular tear which could be leaking, which may have chronic inflammation because of reaction by the granulation tissue, and it could also have trapped fragments of nucleus in the posterior annular tear which need treatment. The access for treatment here is transforaminal endoscopic in awake and aware patient, and the pain in the back can be relieved by removing the trapped fragments of nucleus in the annular tear or by sealing the annular tear. Now we come to a second presentation, which is low back pain, which could be paraspinal. Here the history is mobility of extension is affected because of facet changes, and the pain may increase with extension, and there could be a lag in extension, what we call as a chair exit test. That is, you ask somebody to sit in a chair for a long time, and when they get up from that sitting position, you find that they literally have to climb or extend their back, which takes a long time because they have to do that movement in a sort of slow motion because of pain or because of neurological inhibition. The pain is well localized paraspinal, increases in extension and rotation. Patient says when they turn in bed, the pain increases. There are degenerative changes in the facet joints, generally bilateral. What we do is treating the same level and the descending level above the medial branch. The same level and the descending level above. We treat the medial branch of dorsal ramus, we ablate this branch or we inject this branch and can relieve the pain. This may be ablated on the lateral wall of transverse process and the facet or lateral wall of the pedicle, where it comes in contact with the transverse process. You can show it like this. This is the pedicle wall. This is the transverse process. The nerve is here, which you have to treat. It may be ablated on the lateral wall there by landing at the line, which is the crossing of line bisecting the transverse process and the lateral pedicle line. Now, please remember, when you draw a line along the lateral pedicles and a line across bisecting the pedicle, then the crossing of this line is the point where you land for surgery or injection. You must remember that there is a segmental artery at the lower border of the transverse process which should be avoided, so we always go along the upper border of the transverse process. If in a young person and with non-stiff spine, we normally only manage with a block. In an elderly person with a stiff spine, we may think of ablation of the nerve. Then we come to the third manifestation of degenerative lumbar spine, which is spotty, patchy pain along the lower limb. And the history, there is no history of trauma or infection or ischemia. The pain manifests as heel pain or knee pain. My sign is positive. The early root stretch is positive on sitting cross-legged. I will try to explain this. When you are sitting cross-legged, like most of us in India sit on the floor, you will find that a patient is unable to sit for a certain length of time. After a few minutes, the patient says it is impossible to sit because the pain increases, and it is not possible. The patient has to make the knee straight, otherwise the leg goes numb and the patient's pain increases. This is a sign that the stretchability of the nerve has decreased, and it has decreased so much that now the pain appears, or the patient says that he gets pain right from the lower part of the back to the leg. This has to be treated very, very aggressively. Now this happens, the pain which comes up by sitting cross-legged, as I said, is because of inflammation and a stretching of the nerve root, where the nerve root has become less tolerant to the stretch. Now what we do is, the cause is a proximal annular tear, and this can be seen as a leak in discography. There is a mechanosensitization of the nerve, and as you know that the nociceptor is a pseudo-monopolar axon, and that gives rise to pain which is felt laterally or distally. Now inflammation is the basis affecting the dorsal root ganglion. Because of the leak of cytokine, our access for treatment is transforaminal, and we normally seal the tear or induce the healing of the tear by injecting platelet-rich plasma or ozone or steroid. Now steroid is used in some cases mainly because steroid covers all the cytokines involved in the inflammation here, which are mainly prostaglandins, interleukins, and TNF-alpha. So the patient gets relief of his knee pain and the heel pain by injection inside the disc at 4-5 or 5-1. The next presentation, which is one of the biggest group, is sciatic pain. The pain distribution can be dermatomal, but we know that dermatomes are not that sacrosanct, and they have been described about 100 years back, 118 years or maybe a little more. Now they are outdated, they need revision, they need updating. And when the pain is non-dermatomal, we don't have to go in for Gordon-Waddell's organic signs. It is very, very important to know that we have grown ahead of these organic signs of Gordon-Waddell, and we must know that there are patients who are suffering with non-dermatomal pain. We try to correlate that pain of dermatomal or non-dermatomal distribution with the nerve. We feel the nerve in our clinical examination. The nerve is known to become extremely tender at the common peroneal nerve, at fibular head, at the deep peroneal nerve in the sinus tarsi roof, and the sural nerve on the lateral wall of calcaneus at the heel. Now, images may be helpful in these patients if they have a herniation, to typify the nature of herniation, whether it is soft or firm, or hard herniation, and accordingly we can treat them. There is always a posterolateral annular tear which is leaking with a fragment which is herniated. Our access is transforaminal, and we can tackle all locations of herniation that is central, paracentral, foraminal, extraforaminal. We can use a hook to get all the migrated fragments for removal of the fragment, and normally the opening which is made in the annulus by us, as well as the second opening, which is the main symptomatic opening in the annulus, can be plugged by use of platelet-rich fibrin plug, which we have published before as Derwent plug. Now this is a plug which is made by 15 cc of blood taken from the patient, put in an autoclaved plain tube and centrifuged at 3000 rpm for 10 minutes and made to stand for 10 more minutes. At the end of 20 minutes you get this plug. There are no extra chemical or anticoagulants or any other thing which is added to this, and this is something which costs as little as 10 Indian rupees. So it is one of the best solutions. It's an autograft. You take the blood from the patient himself. And the solution for sciatic pain is what we do is surgery, which is stitchless under local anesthesia in an awake and aware patient. Now the next manifestation is claudication. The important point is normally the sciatic pain which comes from the disc is generally seen in patients where they have pain more in sitting position. A claudication or pain coming from stenosis is normally seen with standing or walking. There we have to note the time and the walking distance which the patient talks about. We have a self-filled questionnaire to be filled by the patient, and there are 3 grades of claudication related understanding. We also do a ultrasound examination for understanding the detrusor dysfunction, which is pretty common in these patients. The literature highlights this point that detrusor dysfunction is commonly associated with elderly people who have claudication. Now we must remember that this should be detected beforehand. The spine is stable in flexion extension, and if it is unstable, we have another subgroup of claudication with unstable spine. If the disc has collapsed, and which allows the upward migration of the superior articular process in the foramen affecting the nerve, then we have to have additionally coronal oblique imaging for the lateral part of ligamentum flavum, about which we are going to talk within a few minutes. The location of the dorsal root ganglion is important here because it is intraforaminal at 4-5. It is just inside the foramen at 5-1, and it is just outside the foramen at 3-4. These are the common levels which are affected in the symptomatic patients. Now, what we have to remember is that dorsal root ganglion is supposed to be at the top of a cone. As you know, cone is a 3-dimensional structure, and the tip of the cone is the dorsal root ganglion, and the base of the cone, or the area, the circle at the base of the cone, is the dermatome. When we talk of dermatome, we may have a wrong idea that the pain is only at the skin, or the pain is only manifest in the dermatome. It's not so. It also manifests the sclerotome, it manifests in the osteum, it manifests in the bone, in the periosteum, etc., etc. So the whole cone is affected. We have to remember that. And in the access which we have for these patients, we go in the upper foraminal area and we target the tip of the SAP, that is the superior articular process. We cut it off as to decompress the nerve in the upper part of the foramen, and we also remove the hypertrophied soft tissue in the upper part of the foramen. We must remember the treatment is by scraping the soft tissue which has hardened or which is giving rise to symptoms. There is no bony hypertrophy, so primarily we don't really have to remove the bone, and decompression of the dorsal root ganglion by removal of the soft tissue and the tip of the SAP is enough in these patients. The last manifestation in our matrix is the unstable spine with claudication. This instability may be symptomatic and as claudication, but there are unanswered questions in these patients with instability which could be still remain a gray area, because even if we do an X-ray inflection extension, we don't really know how much instability causes symptoms or how much is the significant part of instability. We ask the patient to fill up a questionnaire. We go for ultrasound for post-void residue and a standard neurological examination, which may include an EMG and nerve conduction study, is also done. The dynamic imaging, the X-ray, the MRI, the CT gives us proper understanding of the deformity or the instability. We also know that the adjacent segment may be affected in patients who have a previous fixation. We isolate the pain generator in these patients in the foramen, and we may fix the instability by adding our surgery plus stabilization surgery, which we normally do under epidural anesthesia. We know that all pain generators here can be accessed through the foramen and can be treated adequately. 360-degree stability can be induced after total removal of the pain generators as a plan of treatment. We should avoid untimely premature stabilization, and we must remember that the stabilization which we do and which the nature does is not same. We should not equate the auto-stabilization with our induced stabilization. These are two different things. Now, based on this understanding, we will go in for the next stage of root cause analysis. And to put it in a lighter vein, I would say that to address this, solving the problems, we need to utilize our system of root cause analysis or our matrix. I will begin, if I may, by pointing out that it is not my fault to do all these things. Please remember that it is not the patient's fault also. The patient is coming to us for solutions which we must offer in a proper way. Thank you.